Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester from the Overrun here. Danny, today we have a study that is coming out of Japan. So this study is coming out of the Emergency Medical Journal, and this is Yasuda et al. What this study looked at, and this is from October of 2024, so this is still fairly new. They looked at the duration of pre-hospital and in-hospital CPR and neurologic outcome in pediatric out-of-hospital cardiac arrest. So as we've done this series of Journal Clubs, Danny, we've kind of looked for these, what can we find that's EMS specific, right?
Okay.
And there's just this dearth of EMS specific data. So what they wanted to look at was, because we're doing CPR on scene, they wanted to see how effective that is in pediatric patients. The biggest thing they took away was that after 64 minutes, which is a very exact number, but after 64 minutes with pediatric patients in out-of-hospital cardiac arrest. So this is saying you should essentially consider continuing resuscitation if there's no predictors of unfavorable outcome. Now, the other thing here is that the likelihood of moderate disability or better outcomes at 1 month falls below 1% if CPR is continued beyond 64 minutes. So what this study was looking at is how effective is CPR, how long should we do CPR, and what timing of CPR gives us the best outcomes. Why this is interesting, Danny, is we've talked about how the best way to work a cardiac arrest is on scene, right?
Agreed.
You have everything there. You don't have to move. This is kind of suggesting what I think instinctually a lot of people sort of feel, right? Because when we have pediatric cardiac arrests, I think a lot of people kind of, we all blow circuits and we all want to move as fast as we can to get to the hospital. This kind of is leaning a little bit toward that direction, where it might be another one of those gray area type of treatments where, we have to do this for X amount of time, but there also might be a transport component we have to think about.
Yeah, I think that's appropriate. I don't know that there's a lot of medics or EMTs that would be comfortable pronouncing a child in the field absent the signs of obvious death. What this is showing is that survival is possible out to about 64 minutes of resuscitation. I think it's an interesting point that they have this window established, and I think it definitely it's something I'm going to consider in the future, that, kids are a little more resilient. They have less comorbidities. If we can correct the underlying cause of the cardiac arrest, we may get a good outcome. What this doesn't go into is really discussing how severe the neurologic outcomes are and what the survival was. And it didn't go into a lot of the after the arrest stuff. But I think it's important to know that we should probably be working cardiac arrests in children longer. And if we're not getting results in the field, we need to give serious consideration to transport.
I think that's kind of what this is looking at. And just some of the numbers here. So this looked at 1,007 eligible patients. And again, when we talk about cardiac arrest, 1,007 eligible children, 252 achieved ROS. So again, that's still a very low number for outcomes. And 53 had a 1 month moderate disability, moderate disability and of better neurologic outcome. So again, 1,007 patients, 53 of that 1,007 had better neurologic outcomes. So this isn't to suggest
very small percentage here.
We're still not crushing it doing CPR. But one of the things that's mentioned and why this paper came out was it was essentially talking about how to develop TOR, or termination of resuscitation, guidelines for organizations. Because for an adult cardiac arrest, your TOR guidelines might be your standard, 20 minutes in a cloud of dust, right? You come in, you're working for 20 minutes, 3 rounds of epinephrine. All right, we gave it the old college try, and off we go. We know that with pediatric patients, the arrest tends to be respiratory that leads to a cardiac arrest, right? And this is 10,000 foot view. This is not all pediatric arrests. Surely we've all had, outlier patients and all that other kind of stuff, but this is just kind of a writ large type of thing.
Sure.
Where it might be the reality that when you go in to do a pediatric CPR, it might be, and I tend to think it's probably easier to talk about what you're going to do on the way in, right? Okay, you've got the airway, I've got meds or whatever.
Right.
And then discussing like, okay, as opposed to an adult cardiac arrest with this pediatric arrest, let's work it for, 20 minutes and let's see where we're at. And then and just start moving. Right. Where
I don't think that's a bad idea. I think
and
I think it's
in
very
adult
hard.
patients,
I think it's very hard emotionally to do that kind of pronouncement in the field.
right.
I think that this study kind of shows that the window is kind of open. And let's be honest, if we are taking these patients to a children's hospital or a pediatric center, there might be more resources available. I'm not against this. I think this makes sense.
Yeah, and this is just something kind of to add to the bag of tricks, right?
Right.
Where the difference is you go into an adult arrest and you kind of like, we kind of know how this is going to go, right?
Sure.
And I think one of the things that this offers is, again, that cognitive offloading, right? Going into an adult arrest, I think we've all done it a million times. So we all kind of understand whether or not we communicate how the arrest is going to go. I think we kind of have a general understanding of what's going to happen, right? So Danny, you take the airway, I'll take the meds. We kind of know where that goes from there.
Yeah.
And, you apply a CPR device, whatever, and you just kind of go along your way. In this case, I think it might be an argument for building out kind of like the downstream things first, right? So you're going to a confirmed pediatric arrest. Okay, does the closest hospital or the hospital that you might be going to, are they aware that there's a pediatric arrest in the field that's probably going to be coming to them, right? Have your dispatch center notify the receiving hospital, like, listen, they're not moving yet, but, this unit is going to this pediatric arrest and you're the closest hospital. So like, and we can argue whether or not that's a helpful update for the hospital, because certainly a lot of hospitals are going to feel like that's a nuisance update. But again, getting to that position where everyone knows what we have to do, right? There's this kind of ethos in business where you want to make sure everyone knows what success looks like, right? And I think in cardiac arrest, it would behoove us to actually really kind of have that idea. What does the end result here look like? Right? You and I might know that with an adult, we go in, we're going to work it to a pronouncement or to a ROS. But in a pediatric arrest, with all the chaos that's going on, because, pediatric arrests are against the natural order, right? Children aren't supposed to die. So when we get there, there's a lot of stress. You've got all that cortisol coursing through your system, and it can be really difficult to make decisions. And this is where, okay, if we've already established, we have 64 minutes from whenever the arrest started. So time zero is when the arrest started. How long does it take you to respond? How far into that resuscitation are we by the time you get to that patient? And then using that in your toolbox to say, okay, the best chance for this kid to be resuscitated is if we do X, Y, and Z within 64 minutes and get them to the hospital.
Yeah, I love that idea. And I think that reflects, like, we've talked to Dr. Antevi and we talked to other people on pediatrics, and the importance of doing like the pre-planning, like getting the patient's weight before you get on scene and knowing what your epinephrine doses are. Like Dr. Antevi's programs actually draw up the epi as they're going to the scene, and they get there and they're all ready.
Or having pre-filled syringes too. That's another big thing.
Or we can, there's a lot of things you can do. And I think if we look at it from this perspective that we have a 60-minute window, yeah, I like this. Confirm that we've got good CPR. Make sure it's not a shockable rhythm. Get epinephrine on board as fast as we possibly can, even before airway management. Then put an airway in. Then sit back and let's go find out where we're at. Then go to the hospital. We might be onto something.
Right. And again, this study is not holistic. 1,000 is a good end. It's a good data study.
It is.
Of course,
it's not perfect.
No, of course. And of course, there's further research that's needed on it. But we want to know what you guys think. Be sure to check out all of our things on our website and over there on Apple Podcasts. Check out our stories on EMS1. Be sure to click subscribe here on YouTube for the Monday Afternoon Journal Club every week. And for the Overrun of the Monday Afternoon Journal Club, I am Ed Bowder.
I'm Dan Schwester.
And we will talk to you all next week.
Go Birds.
Go Birds.